In this lecture, we will discuss multifocal atrial tachycardia and how it would appear on the EKG. Multifocal atrial tachycardia, or MAT, which is also referred to as chaotic atrial tachycardia, is commonly seen in severely ill elderly patients with acute on chronic respiratory failure, secondary to COPD or congestive heart failure exacerbation. There are a number of contributing factors that culminates in an increase in atrial automaticity. It is this increase in atrial automaticity that results in multifocal atrial tachycardia due to multiple atrial pacemakers outside the sinus node firing at their own pace, and technically we should have at least 3 ectopic foci. So if you look here, what we have going on is that here's our sinus node, okay? If we review our conduction system, we have our internodal pathways coming to our AV node, okay? We have our His bundle. To the right side, we have our right bundle branch, our left bundle branch, left anterior fascicle, and left posterior fascicle. All these end in the ventricular Purkinje fibers that innervate our cardiomyocytes. So what we're saying here is that oftentimes we see these in severely ill patients that have this respiratory infection, okay, or respiratory illness, and it could be due to congestive heart failure or COPD exacerbation. And what happens is we have an increase in atrial automaticity, okay. So what does that mean? Well, here is our atria, okay, and imagine that we have a backup on the right side. Say our lungs are coming off our pulmonary artery, so we get back up in this side. We can have right atrial enlargement, and because of this, we can have an increase in atrial automaticity, and we can have these different atrial pacemakers that fire back, okay. So there's many other things that can contribute to this, but pretty much the end thing that culminates is with this increase in atrial automaticity, and we have these different ectopic foci that are firing and causing these different morphologies on the EKG. Now, what's interesting is that the development of this rhythm during acute illness has been shown to have a sign, or it's been shown to be a sign of poor prognosis in these patients. So how can we identify MAT, or multifocal atrial tachycardia, on the EKG? Well, in order to make the diagnosis, we can boil it down to 4 main things, okay, just like we did with that wandering atrial pacemaker. So we have to see at least 3 ectopic P-wave morphologies. We want irregular P-to-P intervals, okay, and the R-to-R and P-to-PR intervals will also be abnormal as well, as we'll see, and we'll have an irregularly irregular rhythm. We want an isoelectric baseline between the P waves, and lastly, we want a rapid atrial rate, since this is a form of tachycardia, okay? The atrial rate should be above 100 beats per minute, but can range anywhere between 100 to 250 beats per minute. Oftentimes, the rate is between 100 and 150 beats per minute. So let's take a look at each of these features, okay? So the first one we mentioned were the different P-wave morphologies, okay? So again, notice that we have 3 different colors here in the atria. Imagine them as our ectopic foci, okay? We need at least 3 of them to call this rhythm, all right? Just like with the wandering atrial pacemaker. And if you look here, here's one P-wave morphology, here's a second one, and a third one, okay? And this here, number 2, is the same as this number 2, all right? And you can see this 3 here is the same as this P wave there, and this first one is the same as the last one, okay? So they're both all the same, and you can see there's at least 3 different P wave morphologies going on because we have 3 different ectopic foci, okay? Next we said we need to see these P-to-P intervals that are irregular. So how do we do that? Okay, so let's just erase this here, and what we're doing here is looking from one P wave to the next P wave, okay, from one point of the P wave to that. And what we're going to see, if we were to measure all these P-to-P intervals out, they would be different, okay? So all of these throughout would be different, and because of that, we have varying P-to-P intervals. We call that an irregular rhythm, but there's no regularity to this rhythm whatsoever, so it's an irregularly irregular rhythm, okay? So remember, this is just like AFib, so make sure not to mistake this with atrial fibrillation. In this case, we can actually see and make out those P waves there. They just have different morphology, okay? And the other thing we mentioned is we want to see an isoelectric baseline between the P waves, okay? So what do we mean by that? Well, we want to see this, notice here, this isoelectric points between each P wave, okay? So we see that there. We see no flutter waves or anything there. So we want to see that, and we have that here. The other thing we mentioned was the rapid atrial rate, okay? So let's look at the atrial rate here. you can probably already tell it looks pretty fast. So when we look at atrial rate, we're looking at the P waves, right, representing atrial depolarization. So from this P wave to this P wave, notice it's about 1, 2, all right, between 2 and 3. So 300 over 2 is 150, okay? 300 over 3 is 100, and we're seeing that it's somewhere between that range, okay? If we look at the next P to P interval, here's one P wave, here's the next one, okay? So this would be one away, one of the 5 small boxes, okay, or one thick line. This would be the second, and it's between 2 and 3. So again, between that range. If we look at the next one, from this P wave here until this P wave, again, this is 1, 2, 3, so between that range, okay, there's our P wave. So again, you could see it's between 100 and 150, which it commonly is, but most importantly, it's above that 100 beats per minute, so it's a tachycardia, okay? Now, one other thing to note that we said was that the PR intervals will be variable. And why is this the case? Well, it's because it depends on where the focus is located. The longer the distance from the ectopic focus to the AV node, the longer the PR interval will be. And the shorter the distance of that ectopic focus to the AV node, the shorter the PR interval will be. So it should make sense why this PR interval is varying with all these ectopic foci. All right. So if we look here, notice that each one is coming from a different location. Okay. We have one here in the right atrium. We have another one in the right atrium, this one in the left atrium. So the distance between them will determine what the PR interval will be. If we had one right here that's very close to our AV node, we can expect to see a shorter PR interval. Okay, so it really varies based on where that focus in the atria is coming from. Now, intraventricular conduction should not be affected, and therefore the QRS interval should be normal, unless there's some aberrant conduction, which may actually happen when we have these faster rates. Okay, so you pretty much probably noticed that this is very similar to wandering atrial pacemaker. The only difference here is that we have a faster atrial rate going on here. And if you saw that, you are exactly right. So let's briefly review our chart here before we end, so make sure we didn't miss anything. So again, this multifocal or chaotic atrial tachycardia, okay, is a rapid, irregular rhythm arising from at least 3, so 3 or more ectopic foci within the atria, okay? Multifocal, at least 3 or more, atrial arising from the atrial, and a fast rate, okay, above or equal to 100 beats per minute. Some of the causes include COPD and CHF exacerbation. Remember, it's often elderly patients that we tend to see this that have some sort of respiratory failure. The result is all these things, these contributing factors, result in an increase in automaticity in the atria, okay? And because of that, this is why we get this rhythm. The clinical significance, well, it tends to resolve actually after you treat the underlying condition. So say the person has a respiratory infection or CHF or COPD exacerbation. If you fix that, this tends to go away. Now, remember, this has a poor prognosis if it develops during acute illness, okay? And the poor prognosis is not a result of this actual rhythm causing it, but more of the underlying condition. So the main thing here is treat the underlying condition and things should resolve. Now, remember we said these intervals will vary, the P to P, the R to R, and R to and PR intervals, right? We also mentioned this isoelectric baseline between the P waves that we want to see, right, between those, and we saw that. Now remember, this rhythm is irregularly irregular, okay? We also mentioned wandering atrial pacemaker is similar to that, and so is AFib, so make sure that you're able to distinguish them. Remember, the only difference between wandering atrial pacemaker and this one is that in wandering atrial pacemaker, the rate is less than 100 beats per minute, okay? Remember, P waves, at least 3 different morphologies because of 3 different ectopic foci, and because there's 3 different foci, we'll also have a different and varying axes for each one. The P to QRS ratio will be 1:1 because once we get through that AV node or to that AV node, we should be able to get to the ventricles, okay, and conduct them. Now we mentioned sometimes we can have aberrant conduction if all these are firing so fast and bombarding that AV node, it could be refractory to some beats, so sometimes it may not get through. But generally speaking, you'll have a P wave and a QRS complex showing up. In terms of the intervals, we said the PR interval will vary based on where the ectopic focus is originating, and the QRS interval should be normal if we can get through, okay? We also mentioned that possible aberrant conduction because of that bombardment. If some areas of the ventricles are refractory, we can get somewhat of a wide QRS complex, but normally we'll see these narrow complexes occurring. Okay, the main thing is up here in the atria going on. In terms of grouping, no grouping and no drop beats. Okay, well, that's the end of this lecture. We discussed multifocal or chaotic atrial tachycardia and how it would appear on the EKG. I hope you learned something.